I'm Diane Love. I'm a faculty member at the University of Houston Clear Lake, PhDs in accounting, but I teach in the Healthcare Administration program. We have a Master's of Healthcare Administration, and then we have a joint MHA MBA. And I teach in the PIMBA program at Auburn. I teach their healthcare finance class, and then this course, really a policy course. So what I'm going to talk about today is it's going to be a little bit more positive than what you've heard so far today. And I'm going to talk about what's out there, some changes in the law, some opportunities to make some money, those types of things. So we're going to talk about that. And so let me give you the answer first to the consumer-driven healthcare that I took out of here because that's been around for a while. Consumer-driven healthcare is a high-deductible insurance policy. A lot of self-insured employers have gone to that, and what it does is it has the cost sharing with the patient so that hopefully unnecessary procedures and things like that, because the patient has the cost sharing, they will think twice about having that MRI or that CT or some unnecessary procedure. So when you do the question at the end, there is cost sharing in consumer-driven healthcare products. It's a high deductible. We're talking about bundle payments and return to capitation. That's what ACOs are going to be doing. And about your need on bundle payments for you to have a seat at the table and not let the hospital determine who's getting paid what. We're going to talk about out-of-network, and I'm going to talk more on Wednesday about the concierge medicine, but out-of-network, Medicare Advantage and what's happening there, managed care organization profiling. I'm going to tell you a little bit about what we're doing for Harris County Medical Society on that. Some new payment systems and something we're seeing with office-based procedure suites, ERISA, and tomorrow Scott Nichols is going to talk in more detail about ERISA, but I'm going to talk briefly about that. One of the new HOPDs, hospital outpatient departments, freestanding ERs. We're seeing a lot of those. And then we'll briefly mention ACOs, but I think y'all have heard enough of that so far today. Okay, medical home is an ongoing partnership between the patient and a specially trained primary care physician. You have email communication, same-day appointments, quality ratings, and basically it's kind of the best way I can describe it is if primary care is a quarterback, and they have the network. We have now the technology so that you can share information. So if an MRI, the primary care does it, you go to your orthopod, you don't have it done again because you have access to that MRI, not to just to the read, but to the MRI. Most of the medical homes focus on managing patients with chronic diseases. And examples of medical homes are Cleveland Clinic, Mayo Clinic, and a lot of the private payers, it's not just the Medicare programs or the Medicare patients who are doing the medical home, although it was mandated by 2010 that all Medicare patients would have a medical home, which didn't happen because there aren't enough of those. But we're seeing private payers have a big interest in medical home. United Healthcare has a big pilot program in Florida. Cigna, Humana, WellPoint, Aetna also are doing pilot programs. Blue Cross Blue Shield, as you know, each state has at least one Blue Cross Blue Shield program, but they have the umbrella organization, which comes up with their policies and things like that, and they have demonstration programs. When I've been on Kim Dunn's board for 6 or 8 years, and when we first started going to the payers, and we would say, a medical home will manage chronic diseases, we won't be doing duplicate tests, it'll save money. But it costs more because you have to have the technology, and you have to train the employees of the primary care clinic and do all that. And the head of Blue Cross Blue Shield said, well, everybody says it's going to save money, but you can't prove it, so no, we won't do it. They wanted to know exactly what it was going to save them before they ever invested in it. But what really happened was that self-insured employers basically were interested, and they pushed the insurance companies, which were their administrative service organizations, to do this. And so then once the employers started doing it, we've seen all of the managed care companies move forward with these medical home initiatives. And it runs everything from what Dr. Dunn has, which is an NCQA certified medical home. Baptist in Birmingham has several NCQA managed care homes. To one of the things Blue Cross was considering was a group of primary cares in Dallas who were technology geeks who had centricity and ran their own reports, which to me is the biggest waste of time for a doctor to be sitting there learning it at the technology and running their own reports. So it varies, there's all called medical homes, and it varies tremendously. AmeriGroup is a nationwide managed care organization that does Medicare, Medicaid. They're doing medical homes. Okay, talked about earlier about how physician-owned hospitals, about how March 23rd, 2010 did away with physician ownership of hospitals. Well, that's not exactly true. What it did, there was an exemption to the Star Clause called the whole hospital exemption, which basically said a physician could have ownership in the whole hospital, like you couldn't own the radiology department, and you couldn't own the pathology department or the cardiology department. You had to have an ownership in the whole hospital. And it said that unless you were Medicare certified by December 31st, 2010, then physicians couldn't have ownership. It grandfathered in all of the hospitals that already had physician ownership. We had one under construction in Houston that was a joint venture between St. Luke's Episcopal Hospital and their physicians out in the suburban area. They basically did construction 24/7, went from JACO for their deemed status, their Medicare deemed status, to DNV, which is a European company that does accreditation and that's acceptable to the Medicare for deemed status as of 2009. Their U.S. headquarters are in Houston. They come quicker. It's easier to get accredited. They met the deadline. They opened 1st of November. They got accredited. But just because whole hospital exemption went away, there are still exemptions. One is called the large enterprise exemption. And what the large enterprise exemption says is if you have $75 million in net equity, then you're exempt. And you can have physician ownership. And what this is for is people like HCA and Community Health and large hospital companies, so that you as physicians can have ownership in them. And so what we've got is we've got a lot of hospital companies that are buying up physician practice. You have to be a public company. You have to have $75 million in net equity. And so what they're doing is we're seeing mergers of physician-owned hospitals to come up to the level of $75 million net equity. They're public. They're either going public or they're doing a reverse merger with a shell company. And so the physicians can have ownership in there. Another model that's being used is what's called excess funds debt. And what they're doing there is that the hospital is borrowing their generally working capital, which is several $million from a group of physicians. And then what they're doing is a debt instrument, say it's paying 8% interest, but if you have excess funds, if you make a profit, then they use that to pay the physicians who loaned them the money. Does it violate the spirit of the healthcare reform? Yes. But because it's technically a debt instrument, it's legal, because the only thing that it says you can't do is have ownership, and you don't. You're a debt holder. Company that's doing this out of Nashville has letters saying it's legal to do from 7 different national healthcare attorneys. The other model that we're seeing for physician ownership is more of a California model, although we're seeing it all over the country. And what they're doing is they are taking commercial patients only, because Stark only applies to Medicare Medicaid. So if you never take a Medicare Medicaid patient and you only take commercial patients, then it's legal for physicians to have ownership. And so what this means is that the hospital has to be extremely careful to make sure that Medicare patients don't slip through and do that. And then the final thing, and I'm going to talk more about this on Wednesday, is what's called co-management agreements. And what co-management agreements are where physicians form a management company and they manage the outpatient surgery or the inpatient surgery of a hospital. Now, I was talking at the break, I have a client in a small town in Louisiana. Their surgeons went to this ambulatory surgery center, and so when they changed the reimbursement system for ASCs, which we'll talk about in a few minutes, the administrator of the ASC, who was the brother-in-law of the owners, the ophthalmologist, came to the hospital and said, "We want you to buy our ASC, and then you can make it an HOPD, which makes our reimbursement go up 35%. Well, I said, "That's fine, but the hospital has to own 100%. And they said, the administrator said, no, I have a letter from this healthcare law firm that says you don't have to. Well, he did have this letter, but it was undated and didn't account for Start 3. So we were looking at it, and I was doing the financial analysis, and I went to the CEO of the hospital and said, "Why do you want to buy this ASC? Why do you want to do this?" And he said, "Because we want the lead surgeon back, and then all the other surgeons will come because he's taken away almost all of our outpatient surgery." And I said, "Well, let's just get him to form a company and manage your outpatient surgery and your inpatient surgery, and we'll pay him a salary, and then we'll bonus him if he meets certain benchmarks." So we approached him about it, and he thought that was a great idea, and so he did it. And he is now very happy, and he's come back, and all of the other surgeons have come back to the hospital, and they're doing the management. So that's and there on the way here, those of you in the PIMBA class, I sent you those PricewaterhouseCoopers, those PwC reports over the past month or so. And one of the examples of co-management agreement in there, one of my former students who is the COO of a hospital in Huntsville, Texas, a not-for-profit hospital. And the surgeons there, and I had worked with the surgeons, the physician who owned the ASC 10 or 12 years ago. They sold their ASC and their imaging center to the hospital. They became HOPDs, hospital outpatient departments, so they got higher reimbursement. They got hospital reimbursement. Those physicians who had owned the ASC and the imaging center came together and formed a management company, signed a co-management agreement, and they're managing that for the hospital, and they're making money that way. And they'll get the doctors, the surgeons, to agree to use a single vendor for implants and things like that, gain sharing things, and save the hospital. Okay, now here comes the bad news, bundle payments. What we're going to see from healthcare reform is we're going to see bundling of payments, the hospital, post-acute, in some cases the physicians. And what you want to do is have a seat at the table in developing this bundle payments. You don't want the hospital doing it, because the hospital's going to say, well, let's use charges. Well, these hospitals' charges are 500 or 600% of Medicare. Your your charges are probably 200, 250%. And so when you start splitting it based upon charges, you're going to get screwed, the physicians. And so you need to come together to negotiate those rates. Don't let the hospital put it together for you and say radiologists and pathologists have had this all along with their global payment, and that's kind of what it is. Back when I first got into healthcare back in the 80s in Houston, St. Luke's Hospital had an agreement with Cigna to take care of all of their bypass patients nationwide. And they sent them all there. And they had this bundle payment. So the payment Cigna paid them, paid for the hospital, paid for the cardiac surgeon, paid for the cardiologist, paid for the anesthesiologist. And then they turned around and paid the individual physicians. Back then, the biggest problem that we had with that was that the physicians who were part of this, they would bill Cigna directly. And so we'd have to send them bad boy letters and say, no, you can't go around this, you have to do it. But bundle payments, Medicare, supposed to be implemented 2013, 2018, and Medicaid starting this year. And you just need the physicians that are going to be involved in this need to negotiate together. If you're just an individual physician, then the hospital's going to set the rates, and they're going to set what you're going to get, and they're going to get more of the money than their fair share. Okay? And it includes the hospital, the physician group, SNF, LTAC, home health. It includes all of the potential cost on that. And then you have to develop the methodology for distributing the payments. And so you're negotiating the amount of the global or the amount of the bundle payments, and then you're going to end up deciding on the distribution. So you want to have a seat at the table and have your input in how to negotiate it. Key responsibilities, accountability for quality, cost, and overall care, how you're going to structure the distribution, adequate choice of providers, and then care coordination on there. Okay. Risk contracting is coming back. I was talking to one of the physician executives at University of Texas Medical Branch in Galveston when we first got healthcare reform. And Dr. Raymer and I were laughing about, Back to the Future. I mean, we saw all of this ACO stuff in the 90s, only we called it integrated delivery systems. And the hospitals bought physician practices, and they became payers, and we went through all of this, and that's when we had the growth in the HMOs. And so what we had was capitation, and we had risk contracting. And so instead of the insurance company having the risk, the integrated delivery system had the risk. And basically, capitation's real basic, and we're going to go through this and look at it. You predict basically the frequency, and you predict the cost of services. But the issue is estimating this correctly, so that if it costs less to provide the care than what your cap rate is, you make money. If it costs more, you lose money. And basically primary cares, you got to have a sufficient volume for it to work right. When you see the ACOs that they're doing, they're saying 500 Medicare patients. You probably need 50,000 Medicare patients when you consider the cost of technology for this to work. Okay, let's look at, first you got to decide who's responsible for what. So you have the HMO or the ACO that's responsible for marketing and employer billing and eligibility and out of area. Out of area is more than 50-mile radius from where you live. Like if I fell down and broke my leg up here, that's out of area. And then transplant or AIDS pools, the high cost. Then the physician group is responsible generally for all physician services, inpatient and outpatient diagnostic services and treatment. And then the hospital is responsible for everything else. But generally, when you're talking about transplants, you buy a rider that reinsures for that, so that nobody really takes responsibility for that. But you have what's called a financial responsibility matrix, and you go down and you list every service that you're going to be providing and who's responsible for it. And back in the days, in the 90s, I had a big IPA, and they came to me because they had negotiated capitation, and they had risk for AIDS. And they know they had risk for AIDS, and they didn't buy the rider to pay for that, and they had like 3 cases that the physician group was going to have to come out of pocket for. And fortunately, it was a minority IPA, which helped the payer get the governmental contracts, and they couldn't afford to bankrupt the IPA, so they picked it up. But you make assumptions to the expected utilization, and pretty much if it's a commercial patient, they see their primary care 3 times a year on average. If it's a Medicare patient, they see their primary care 9 times a year on average. I mean, it's how the insurance companies come up with their rates. You have an actuarial firm like Towers Perrin or Millman and Robertson that comes up with how many times do you have office-based surgery, primary care? How many times a year do you visit your physician? Then you come up with the average rate per service, and that's pretty easy because you go see what the marketplace is paying, and that's pretty easy. And then you multiply them together to see what the cost is for that payer and subtract the copay if there's a copay. The problem is getting the utilization correct, because if you're a pediatrician and you have adverse selection, which means you're great at doing asthma kids, and you have a reputation for that, and so all the asthma kids come to you, then your utilization is going to be higher than what the actuary represents. My same little hospital that I did the co-management agreement, they've been a client of mine for 20 years, or longer, I guess now, because the first thing I did for them was an HMO with the school board. And there was a law in Louisiana that said if you're a state employee or governmental employee, I guess, you could opt out of the Social Security system. So their school board, who we were negotiating the HMO contract with, their school board, 25% of their covered lives were retirees, where the primary payer was not Medicare, the primary payer was the school board. So this HMO had gone to Millman and Robertson's Minneapolis office, which was the best office there was, and had gotten the projections. But I had this little chain-smoking, Twinkie-eating CFO there who could tell me anything I wanted to know. He knew exactly what the utilization was for the school board. And so Jack gave that to me, and it was significantly higher than what Millman and Robertson had said. So I had the woman who was the CEO of the HMO was just a witch. And so I had her come for a 2:00 meeting on July the 3rd for us to talk about the contract. So she came and she said, "Oh, we've already negotiated the rate with the school board, and so we have to do the, you have to sign this and all of this." And I said, "Well, let's call your actuary." So we did a conference call, and the actuary said, "Diane's right. I didn't know that 25% of the covered lives were retirees and with Medicare as a secondary payer. So, yeah, I gave you too low rates and too lower utilization. And so that's what you need to sign the contract." Well, no, we're not doing it because we already agreed with the school board on what the contract is. And they weren't going to get paid any more money. And so, ultimately, because they'd signed the contract and they had to have providers, they ended up agreeing to what we wanted to. And they lost a whole bunch of money and they went out of business, But that's where your big risk is, because how they come up with these numbers is how they buy paid claims from employer groups, okay? And so they take a sample of the claims. Well, that sample may or may not match the people that actually choose the ACO. Their utilization may be different, like I talked about the pediatrics adverse selection for asthma kids. And so when that happens, what happens is your rates are wrong, and you're gonna lose money on it. Okay. Once you multiply them together, subtract the premium, the copay, and that's the cap rate. Here's an example, and it's just very basic. It's primary care. Office visit, 3.015 is the frequency. The cost, level 1, $38.20. Office surgery, 0.039, immunization, 0.36. And you just go down and say, okay, what services is a primary care physician for? And you list them out. Then you look at the frequency from the actuary, and then you assign the cost to them, which is easy to come by the rates in the area. Then your per member per month, you multiply the frequency and cost together, divide by 12. So here's a per member per month. Okay, this is a basic medical, $13.31. But if you're a primary care, part of your money comes from the patient and the copay. So you have to adjust for the copay. In this case, we took our basic medical, then $15 office copay times the frequency, 3.06, whatever, 3.015, and that's how much you get from the patient on an annual basis. Divide by 12, because we're doing per member per month, and your primary care capitation is $9.54. I mean, the methodology is very basic. There is nothing to it. But the big problem is getting those frequency correct for the people who choose you to have the same frequency as you used in your calculation. A quick and dirty way to do it is to look at all of your patients from a certain payer and see how much you collected from them last year. Compare that to your basic medical times the number of patients, and they should approximate. But the big problem is if you get adverse selection in there, you could end up losing a lot of money. Out of network. This is where physicians and facilities, they don't contract with managed care organizations, okay? And they can do concierge medicine. As I said, I'm going to talk about that more on Wednesday, but concierge medicine means you take a fewer number of patients and they pay you and they get preferential treatment on there. And you aren't contracted with payers. All your money comes from the patient. Okay, out of network, generally they waive the out of network differential, which means that if the most common rates are, if you're in network, the employee pays 90 and the managed care company pays 90%. Out of network, the patient pays 40 and the managed care company pays 60% of charges. If it's 90-10, it's of the contracted rate. Well, you're supposed to collect 40% of charges from the patient. If you did that, nobody would come back. So what they do is they waive the out-of-network differential, and if the contract waives 125% of Medicare, you charge them 10%, 12.5%. And then if your charges are 500% of Medicare, you charge the insurance company 60% of 500%, 300% of Medicare. The issue is you have to comply with state laws, and different states have different laws. And so in Georgia, what you have to do is you have to get written permission from the managed care company prior to waiving the differential. You have, which no, the payer isn't going to give you that. Or you may have to file paper claims. You may have to disclose, because you have to disclose that you are treating this out-of-network patient as if they were inpatient and waiving the differential, which means you have to file a paper claim. I have seen some facilities who have separate tax ID numbers, one for inpatient and one for outpatient. And they will take some patients under one, bill one under one tax ID and bill other ones under a different one. The risk of billing out of network is Medicare, anti-kickback, fraud and abuse violations if you're waiving that out of network differential. If you're not filing paper claims and not stamping that claim with the fact that you're waiving that out of differential, in some states that's insurance fraud. There is a risk that you across the board waive the out of network differential. That becomes your new charges on there. And then you have the Medicare organization's policies. And those are, they'll say, okay, because you're not a contracted provider, then you're not accepting assignment, and we're paying the patient, and you chase the patient. That's what they do in Florida. That's what they do in the Mid-Atlantic states. And that's fine. A lot of your ASC companies love that because they just set up a system and go chase the patient, and they get paid. If you don't do that, though, then that patient isn't going to, out of the goodness of their heart, bring you that money. Some of them play a flat rate regardless of the procedure and apply the out-network differential. For example, they say whether you're in-network or out-of-network, we're paying you 125% of Medicare. If you're in-network, you get 90% of that. If you're out-of-network, you get 60% of 125, which is 75% of Medicare. Or they access a third-party contract like Vant or Three Rivers. A lot of them now, this is the model United Healthcare uses, where you change the benefit design. You do an exclusive provider organization. And on that, what that means is that you're going to have to verify not just eligibility, but benefits. And if they have no out-of-network benefits, you don't want to take that patient on there. Termination of physician contract for referring out-of-network. Some states do not allow you to do that. We have payers that will call the patient. Their fraud division calls the patient and says, did you pay that 40% of charges? And if they didn't, then they go back on it. Okay, and now we're seeing, in addition to the EPO and the fraud division, what they're doing is they are providing cost information to their insured on the physician in the facility. And they'll say, okay, you're having this procedure done, give them your zip code, and here are the different ASCs in your area. And here's what we estimate the cost to be at each one of them. And so what they're doing is they're steering the patients to the out-of-network, away from the out-of-network. MultiPlan, which is owned by Vant, is a wrap network, and that's the example I gave. If MultiPlan has a contract for 200% at ABC Hospital, the managed care organization's 90-10 in-network and 60-40 out-of-network. Hospital charges are 500% of Medicare. Okay. If you're an Aetna patient, you don't have a contract with the facility, you access the MultiPlan contract. And so you pay 60% of the 200%, not 60% of the charges. So that they are basically accessing these networks. But a lot of out-of-network facilities will sign networks with MultiPlan, more with Three Rivers, because you can do a Three Rivers contract at 95% of charges. So you sign a contract with Three Rivers, and then they apply the 60% to 95% of your charges. So that's fine. You're making good money. There are a lot of out-of-network facilities who want these route networks where they can negotiate high rates with them. Okay. The employer response is no out-of-network. And then, as we said before, they're paying the patient. Some are paying usual and customary as opposed to paying charges. And then some of them have the consumer-driven health plan, where you have a $5,000 deductible. So the employee has to pay that first $5,000, and they pay it at 60% of charges. Okay, what you have to do if you're an out-network provider is verify both eligibility and benefits. Historically, you have verified eligibility. You want to know, do they have out-of-network coverage? If they do, then you want to go ahead and treat them. But if they don't have out-of-network coverage, you want to send them to the hospital or to somebody who has a contract, because you want the insurance company isn't going to pay you, the patient is, and you want to do that. You need to, if you're an out-of-network provider, is track your gross collection ratio by payer. Gross collection ratio is your collections divided by your gross charges. So if it's working for you, that should be 60%. That means that everybody has out-of-network coverage, because the 60% is the percent they're paying you. So you track it by payer, and as it goes down to 50 and then 40%, then you probably need to get in network with that specific payer. And so you're monitoring it, because you want to ride the out-of-network as long as you can, but what you don't want to do is think you're getting paid. I had this ASC company, and one of my former students is now the CEO of it, and they basically, with Cigna, they hadn't been paid for like 2 years because they didn't have any out-of-network coverage. And so they had just discovered this because they had only been verifying eligibility, and they wanted to go and sue Cigna. Well, if they didn't have out-of-network benefits, they're not going to pay you. The other thing, and this is real important, and this is what Scott's going to talk about, and for those of you in the PEMBA class, I emailed this to you, the ERISA assignment of benefits. Basically, I'm sure most of you are familiar with Med Solutions, which is a national company that does pre-certification on imaging. Okay? There is an out-of-network hospital in Houston that Med Solutions didn't pay, and so they sued Med Solutions for the amount for the imaging procedures. The judge threw it out of court because your standard assignment of benefits assigns the right to collect from the insurance company. It does not assign the right to sue the insurance company. Their assignment of benefits for this out-of-network provider did not give them the legal right to sue for those benefits. So it got thrown out of court. The judge said, okay, you can't, if you want to reinstate this, you have to go back to all of the patients and get them to sign this new assignment of benefits, which assigns you the right to represent them legally to collect this. So what I sent you was the assignment of benefits form. You need to change, especially if you're an out-of-network provider, you need to change your assignment of benefits so that you can go to court on it, so that you have legal standing. Okay? Okay. Medicare Advantage, which is a Medicare HMO product. And it's been around, again, we had it back in the 90s, and it went away, and then with MMA of 2003, it came back, and it's a Medicare HMO. And basically, the the Bush administration wanted to get out of the business of paying Medicare claims, and they wanted to basically privatize Medicare, and that's what Medicare Advantage is. People like United Healthcare, most Blue Cross Blue Shields, Humana have a Medicare product, and basically the Medicare patient can enroll in this, and they're no longer a Medicare patient, they become an HMO patient, and they're locked in for 12 months. Well, the Medicare Advantage has cost more It costs more than fee-for-service Medicare. So the Obama administration wants to do away with it because it's costing the government more than fee-for-service Medicare. And in 2010, we saw a 14.6% increase in premiums that the Medicare recipients paying. It's experiencing accelerated growth. Enrollment went up in 2012 by 10% to almost 13 million Medicare recipients. Premiums went down in 2012. We reversed the trend in 2012. You have an annual lock-in requirement, which that means they can only change once a year, and it's generally towards the end of the year. And then again, this may or may not go away with ACOs. The Obama administration may get rid of it because they say that the managed care companies are making too much money. What you see is that the managed care organizations that have the Medicare Advantage product and the ones that are offering Medicaid, most states are doing a Medicaid HMO, especially in their urban areas. And so basically they're doing all payer contracts. So if you want the commercial patients, you also have to sign the Medicare and accept Medicare patients from the HMO, and you have to accept Medicaid. So you can't cherry pick your patients anymore. Medicare profiling, we're seeing a lot of profiling, and where they're looking at things like test ordering, cost, admissions, use of alternatives, and outcomes and quality. And so what they're doing is they're saying we're going to do smaller networks with our more efficient providers. They're profiling those providers. And some of them are terminating the contracts with the providers that they consider to be inefficient, costing them more. Some of them in anticipation of 2014, when the insurance coverage goes into effect, are getting rid of the providers. And so a couple of things that are happening on this, like Blue Cross in Texas has what they call their Blue Star physicians. And so if you're an efficient provider, they give you a little blue star in the directory. So as those of you who are in my class know, I don't like many of the people I work with at all. And I just think fortunately we fired our program director, so I no longer have chest pains after faculty meetings. And so he got fired in December. But we have this one that I especially don't like, and he has some sort of heart thing, and so he needed not a cardiologist, some very specialized. So he went to the Blue Cross Blue Shield Blue Book, and he found somebody who was a Blue Star, whatever the specialty is. And so then he asked me, I mean, he's a healthcare administration professor, and he doesn't know anybody. And so he asked me who should go to. So I called my friends at Methodist, and they said, well, if this is for, yeah, he's a good guy, he's a good doctor, but if this is for you, I would take this doctor, that doctor. And I called my friends at St. Luke's, got the same thing. My friends at Herman got the same thing. And, if this is for you, I would select another doctor. Of course, I never told my colleague. And so he was so proud of himself because he had a Blue Star doctor, and he didn't understand what Blue Star meant is you were the least expensive because you didn't advocate for your patient and get extra tests done and those kind of things. And so that basically what we're seeing is that they're profiling physicians. And then we're also seeing the upside of profiling, where you're doing the PQRS for Medicare. Most of your managed care companies have quality indicators, that they're measuring, and if you achieve those benchmarks, you get paid more money. And so what I'm doing is working with the Harris County Medical Society in Houston to use our graduate students as interns or as class projects to enter this data for them. And we're running the numbers right now, but we think a primary care physician who participates and hits the benchmarks can make $5,000 to $10,000 more a year by the payments for these quality indicators. And so we're going to see more and more profiling. You already have to do the Medicare, the PQRS, but different payers are doing different things. And so it's probably going to be worth your while to have people entering this data for you. You either get, if you don't meet the benchmarks, you get dropped from the network, they pay you less, or you're not in their preferred network, which they sell to their big commercial employers, which is who you want on there. Physician responses, the ones with adverse selection can be at a disadvantage, as we talked about earlier. And we're seeing the different medical societies survey the physicians to see what they think of the managed care companies. We did this for Harris County, and we did this for Bexar County, which is San Antonio. And what we found was the only thing they thought managed care companies did a decent job of was their pharmacy management, because that's what they'd had the longest period of time. And they thought they did a terrible job at everything else. Of course, the managed care companies thought it was terrible that we profiled them. Okay, we talked about the ambulatory surgery centers, and y'all did a project last semester in the finance on this. But what we're seeing is that they did a significant number of procedures that can now be approved for ASCs. This came out in 2008, but also have been approved for office-based procedure suites. And what happens on that is that you get a side of service differential if you do it in the office. And so if you are in a certificate of need state, there aren't a lot of ambulatory surgery centers. So your choice is doing it in the hospital outpatient, and it costing $10,000 to $12,000, or doing it in an office-based procedure suite that costs $1,000. And the first part of this year, I saw one of the major national payers say they will not pay an ambulatory surgery center for procedures that are approved for office-based procedure suites. And so the side of service differential that they're not going to pay for, GI, pain, and some podiatry procedures. And this is the first time I've seen this proposed in a contract, but they're saying, you know, an office-based procedure suites they're not licensed, but Aetna requires that they be accredited by JCO or AAAHC. None of the other payers require that they be accredited with the Medicare deemed status, but there is a move toward office-based procedure suites out there. And just as we saw procedures move from outpatient, hospital outpatient surgery to ambulatory surgery centers, we're now seeing them move to office-based procedure suites. There's a modifier that you have to put on the claim, and it's a single claim, and it's paid under one tax ID. There was this one company, an ASC company, that tried to open up office-based procedure suites and bill for the side of service differential. Well, by definition, you can't do that because it's a side of service differential. And so it's got to be office. In the office, the physician has to bill for it. And pretty much what happens is whoever sends the first bill gets paid. So that if the office-based procedure suite sends it, they get paid. The doctor sends the bill, they don't get paid. Okay. The new APC methodology that Medicare uses, they don't pay for implants. And what we're seeing there, United Healthcare has their own homegrown APC rates that include the implants. And I mean, a cochlear implant can be $35,000 to $40,000. So, you know, you better know what your top 25 procedures are that you're doing in the ASC, know what the implant costs are, and then do a financial analysis before you do a contract for an ambulatory surgery center. Okay, one of the other new things are freestanding emergency departments. And basically, urgent care centers do not get paid a facility fee. They're just like a physician office, after hours physician office. But in some states, you can have a freestanding emergency department or a freestanding emergency hospital, and it gets paid the facility fee, the professional component, and the facility fee. And basically, they have to have appropriate arrangements for transfer of patients. They have to have 24/7 coverage by ER physician and nurse. They must have all the equipment and supplies for provision of emergency care services. They must be accredited by JCO or AAAHC. Some of them are trying to become HOPDs, hospital-based outpatient department. I have problems with the business model, how it works, how you will have all this cost of 24/7 coverage by ER-trained physician and nurse and all the equipment and supplies that a hospital ER would have, and how you're going to get paid enough for this to work. Because if I'm experiencing chest pains, I'm not going to a freestanding ER center. I'm going to a hospital with a heart program. And I'm not going to go if I have something that requires an MRI or a CT and this expensive equipment. I mean, my son loves them because he separated his shoulder and he went and he only had to wait 10 minutes and it was, you know, and his insurance paid for it. But you don't get enough money for that to pay for all of your costs. And that's why some are trying to become HOPDs, and you got to really meet the requirement for that. It's not just being within 35 miles of the mothership for that to work. The other things you have to be concerned about, some of them are going to the hospital and want to be an HOPD, and then in exchange for transferring their patients, their high-level patients, to the hospital. But they don't understand with managed care companies, if you go to the hospital, go to the ER, and then you're admitted to the hospital waives the ER charges. Because if you get admitted to the hospital, they get a per diem or they get a case rate, a DRG, which includes everything that was done in the ER. So the managed care company is going to pay you twice. And so all those high-end things, you got to get your money out of the hospital because the managed care company isn't going to pay you for that. The other thing, it's almost impossible to get the managed care company to pay for the ambulance to transport you from this freestanding ER to the hospital, which means the patient has to pay for it. And so you better have some sort of arrangement with an ambulance company for discounted rates and stuff like that. It's not just setting up a freestanding ER and having all of this and then getting JCO accredited and now everybody's going to pay you. It doesn't work that way. You need to be very, very careful with this. Okay, ERISA plans. ERISA plans are the self-insured. And depending on which state you're in, 75 to 85% of the commercial business is self-insured. The stronger your patient protection regs, then the more likely that the employers are self-insured. We saw starting in 2007, 2008, a lot of the plans, a lot of the companies going bankrupt, not funding their health plan. These people are not regulated by the state insurance board, and therefore they run out of money, you don't get paid. So what you need to do is to monitor your days in accounts receivable by payer or by employer group. If you're in the suburbs of a large city, then probably the largest employer group is going to be your school district or anywhere. The two largest employers are the government, county or city government, and the school district. You need to be monitoring by that. And monitor by employees your days in AR, and when they start going up and up and up, you need to be making sure you get paid because you could end up with delivering care and getting nothing. Okay. In Texas, we have a prompt pay law that says you have to pay within 30 days on an electronically transmitted claim, or if it's a disputed claim, you have to pay notify the provider and pay 80%. Okay? This law is a Texas state law, and the managed care companies who are doing the administration of these plans have stated it's an ERISA plan, it doesn't fall under state law. Well, a couple of years ago, the Fifth Circuit Court of Appeals held that the Texas prompt pay law applies to ERISA. And this has been the first successful challenge to the ERISA exemption. So we're probably going to see more and more self-insured employers fall under state laws requiring prompt pay or requiring different types of payment. Okay, again, we've talked enough about accountable care organizations. The only thing that I would say to it is I don't think Medicare ACOs are worth the cost of setting them up. Because you have a shared savings plan where you get a very small return on your investment if you get any return at all. Where ACOs work are on commercial plans. And basically in California, where they did some ACOs and affiliations, hospitals and physicians, they had more market presence and they were able to negotiate higher rates. Unfortunately, in the regs that came out with ACO, the Federal Trade Commission said in order to get antitrust exemptions for an ACO, you have to be a Medicare ACO. And we're seeing some of the big hospital systems who have done clinical integration and everything else now equivocating on whether or not they're going to become an ACO. Because they're just, it's going to cost you, the information systems, the costs are exorbitant, setting up everything, and then you're going to get very minimal shared savings if you get any shared savings, and it just doesn't make sense. Once the final regs came out last spring, people just aren't looking at doing that.